All right, g'day. My name's Pat Auger. I'm a critical care paramedic working out of Ontario in the city of Ottawa, located in Canada. And we're going to be reviewing distributive shock secondary to anaphylaxis. A little bit about our program in Canada. I work for Orange Transport Medicine, which is the critical care transport provider for Ontario, Canada. We service a population base of approximately 15 million people, and we have bases strategically located across the province. And we primarily work in a paramedic to paramedic crew configuration. So normally two critical care paramedics. And what we're generally involved in is critical care transport. So the vast majority of what we do is we service smaller peripheral hospitals, nursing stations. We do some on-scene work, and we have a variety of aircraft, such as fixed-wing aircraft, rotor-wing aircraft, and land critical care transport units. So we are certainly involved in moving high acuity patients. We move a number of patients in shock states, and we certainly, on at times, deal with anaphylaxis. And so I wanted to start with this talk around distributive shock and just reviewing some basic concepts around anaphylaxis. And so one of the things that's important to note is, some of our most common presentations. So the most common presentation, which accounts for 70 to 90% of patient presentations with symptoms, usually peak around 30 to 60 minutes, and they're usually completely resolved within an hour. And we've got a number of common causes, related to food, medications, venom, which I would not say is so much a common cause that we run into in Ontario, but it is listed as a cause. And for the most part, our land ambulance or land paramedic counterparts in our peripheral hospitals are able to manage this situation quite well. And so when we look at the epidemiology of anaphylaxis in critical care, the vast majority of patients, as I said, are going to be treated and released at a local facility when we're dealing with anaphylaxis. But there is a small subset that will require critical care interventions and retrieval back to tertiary care. And this is where really our role as critical care paramedics, certainly in the province of Ontario, comes into play. And there was a study done that reviewed just over 38,000 patients, and they looked at how many patients would require acute care. So how many would be hospitalized, require intubation, mechanical ventilation. And so like when you break this down here, 38,000 patients coming into various emergency departments, about 11.5% were hospitalized. About 5.3% of that patient volume required ICU admission. 1.5% was intubated. But the vast majority of patients seem to be just discharged and treated and managed within the emergency department. And so our typical management for us pre-hospitally is in our medical directives and standing orders, or is a combination of the administration of epinephrine and antihistamines such as Benadryl or diphenhydramine. And then we actually have steroids within our medical directives. There was a cross-Canada anaphylaxis registry and evaluation of pre-hospital management. It was basically a pan-Canadian study that span 5 provinces over a 6-year period, and it involved 9 emergency departments, and they looked at just over 3,400 cases that they reviewed. And what they found was epinephrine was administered in 31% of the cases, and antihistamines and corticosteroids were administered in 46% of the cases. And the bottom line out of this study was the admission to intensive care unit was associated with treatment of corticosteroids. And the study concluded that pre-hospital administration of epinephrine and antihistamines may reduce uncontrolled reactions. And so I think it's important to emphasize that epinephrine plays a significant role in the treatment of anaphylaxis, but in addition to that, the treatment of distributive shock. So I just want to review quickly some basic principles around the pathophysiology and how we get to anaphylactic shock states. So normally there's an exposure to an allergen. There's IgE antibodies that bind to both basophils and mast cells. And after a re-exposure, the IgE antibodies trigger an inflammatory response, and there's mediators that are released, such as histamine, leukotrienes, and platelet activating factors, which really result in peripheral vasodilation and edema. And so the vasodilation decreases systemic vascular resistance, and essentially a distributive shock is produced. And the inflammatory mediators also cause a capillary leak. And so with that capillary leak, there's third spacing, and there's fluid lost into the interstitial space, and there's a relative hypovolemia that can be developed. And then there's sort of concurrent complications with respiratory complications. So the inflammatory mediators can cause edema to the airway, airway constriction, and mucosa edema can lead to lower airway obstruction, and this can complicate the management of this particular shock state. Now, there's some clinical features of anaphylaxis, and I really want to focus on the cardiovascular system. It's the hypotension, hypovolemia, and hemoconcentration due to fluid loss, and tachycardia and arrhythmias that we see that can develop in this distributive shock pattern. And it's really important for paramedics to think about distributive shock with respect to anaphylaxis, because I know a lot of anaphylactic cases are managed quite well with simple administration of IM epinephrine and maybe an antihistamine. But we really want to think about this possibility, and we often associate distributive shock with septic shock, but anaphylactic shock can cause this condition as well. So with our physical examination, we certainly want to follow airway, breathing, circulatory disability, a normal assessment. We're looking for anything that might obstruct the airway, like angioedema. We're looking at respiratory rates, the level of distress. We would certainly want to auscultate and look at the presence of wheezes. But from a circulatory standpoint, we're really looking at skin color, condition, cap refill, peripheral pulses, temperature. We're looking at blood pressure, and generally trying to identify those patients that are hypotensive. So this could be a systolic of less than 90 or a 30% decrease off the baseline. And the other thing that we'll generally have access to is urinary output. And so certainly we, on many of our patients, we assess the level of mentation. Syncope, headache, seizures are example, and then we are assessing exposure, and so we're looking for signs and symptoms. But again, when we're thinking about distributive shock, we're really focusing in on that circulatory component to anaphylaxis, and recognizing that the other respiratory components can further contribute to a bit of a vicious cycle. There are some relevant investigations that we can consider using. One that comes to mind, and we use this in our program, is the shock index. And this is just where you divide the heart rate by the systolic blood pressure. And a normal shock index is between 0.5 and 0.7. And it's been found that indexes of 0.8 to 0.9 or greater are associated with a higher level of care requirement. Requirements for not only fluid resuscitation, but also vasopressor support, including mechanical ventilation. And so positive shock index or increased shock index may help us triage patients. They may help us around expected clinical course in our management. The other relevant investigation is looking at the serum lactate, which is basically a biomarker of tissue hyperperfusion, and the clearance of lactate. I know there's been quite a bit of discussion on the use of this pre-hospitally, but certainly in the Ontario context, working out of Canada, we have our patients for prolonged transports. And so the clearance of lactate usually occurs over anywhere from a 2 to 6 hour time span. And we do have a trigger of around 4 millimoles per liter should alert the paramedic for the need for resuscitation. And it's something that we can also use to monitor the progress of our resuscitation. So ideally, over several hours as we're transporting our patients, we should see that serum lactate decrease. And then the other thing that we have available too, and we related to our point of care testing, is thinking about a blood gas and being able to monitor our normal hemodynamic parameters. And so as patients decompensate, whether it be from a respiratory standpoint or a metabolic standpoint, they quite often may initially develop a respiratory acidosis, but they can certainly develop a metabolic acidosis, and they may present with a metabolic acidosis. And so our appropriate fluid resuscitation and use of vasopressor support may be viewed and assessed when we are resuscitating our patients. And so we can see improvements off the arterial blood gas with serial assessments of that. So as we transition back over to epinephrine from a critical care standpoint, we know that epinephrine has a number of positive effects, not only in the management of anaphylaxis, but specifically distributive shock, as it binds to A1 receptors, which causes vasoconstriction. It binds to B1 receptors, which increases heart rate and myocardial contraction. And this can improve forward flow and improve oxygenation and oxygen delivery to the tissues. It also binds to B2 receptors and can promote bronchodilation and provide some of that symptom relief. We use weight-based in our program, and this is an example of an epinephrine infusion. Our general dosages are anywhere from 0.1 to 0.5 mics per kilo per minute, and we generally titrate this to a targeted MAP of greater than 65. And generally what we do is we mix 4 milligrams and 250 to get a concentration ratio of 16 mics per mil, and we put it on an infusion pump. The other thing that we do for pre-arrest patients is we do have the option to go with push dose epinephrine, so 5 to 20 mics IV for temporary improvement while we're mixing the infusion medication up, because sometimes it takes a little bit of time to do that. In the area of oxygenation and airway management, I think for the most part as CCPs, it's supportive care. We've got some recommendations around targeted O2 sats around 94 to 98%. We're really looking at symptomatic relief when we're considering utilization of Ventolin. And so, it's really important to note that Ventolin is not a replacement for epinephrine. And so epinephrine is primarily recommended for the management of anaphylaxis and or distributive shock. And then, in the area of supportive care, if there's indicators for airway protection, patients that don't have the ability to appropriately oxygenate or ventilate, then a rapid sequence intubation as a CCP may be indicated. And I would think in the area of anaphylaxis, the medications of choice in our program are ketamine in particular for its positive hemodynamic effects, and then rocuronium as a paralytic. With respect to fluid administration, generally you want to establish 2 large bore IVs. You could ask the sending facility to establish a central line, as that in Ontario that's currently outside of our scope of practice. For difficult IV access, certainly the intraosseous route is a good choice. And I think what's important is these patients develop fairly significant fluid volume deficits, and so we should be prepared to administer an initial bolus of in upwards of 30 milliliters per kilo. And some of these fluid volume deficits can reach 7 liters in some patients. And so, you know, using appropriate crystalloid isotonic solutions such as normal saline and Ringer's lactate is important. And again, we're going to maintain targeted maps of 65 or greater. And we can monitor the pulse pressure and monitor capillary refill as we reassess our patients. And then concurrently, it's important to ensure that we're running fluid maintenance as well on these patients. Now, what's interesting in the literature is we do have some options, additional options that we carry as CCPs on Ontario, some of these medications to consider with distributive shock. And so for patients that are beta blocked, they may fail to respond to catecholamines such as epinephrine or epinephrine infusions. And we just want to keep in mind for some of our cardiac patients that may be in anaphylactic shock that are prescribed beta blockers, that the administration of glucagon is an option. And we often call glucagon a bit of a backdoor because it activates adenyl cyclase, but it basically has a positive inotropic effect as well as causes bronchodilation and can enhance vasoconstriction. Vasopressin is a medication that we carry. We often utilize this in the setting of septic shock. We quite often think of it as a second-line agent in septic shock, but there isn't any reason why we can't use it in distributive shock. Vasopressin does not target adrenergic receptors, and it's not considered a catecholamine, and so it essentially binds to V1 receptors and causes vasoconstriction, and B2 receptors, which causes the kidneys to retain water. And so this could be concurrently utilized with the administration of epinephrine. The Canadian Critical Care Society, within their clinical practice guideline, they recommend using vasopressin or vasopressin analogs in critically ill patients with distributive shock, and it's been shown to decrease mortality as well as decrease the incidence of atrial fibrillation. And so in some ways what it does is it allows us to decrease maybe the amount of catecholamine that we're using. Now, finally, one medication that has come up that we don't carry as critical care paramedics, but I have run a couple times, I think in the last year and a bit, is methylene blue. And this is sometimes initiated by sending medical facilities. And it's a nitric oxide synthesis inhibitor. Basically what it does is it blocks nitric oxide synthesis, and it stops the process of vasodilation. And what it can do is it can enhance the ability of epinephrine and other catecholamines to work. So this is just a quick review to think about distributive shock. Certainly as critical care paramedics, there's a patient safety and resource management issue. CCPs can take the lead role in making recommendations for some of these second-line medications. We may need to explain to other healthcare providers the rationale for adding some of these different medications. One of the things that is important is to think about being a patient advocate and to think about expected clinical course. And then in and around our transport decision making, we want to ensure that our patients are transported to the most appropriate facility. And so, the threshold to escalate when multiple doses of epinephrine have been administered. Another example might be when you have a positive or increasing shock index. And certainly for refractory or distributive shock, the receiving center should be capable of caring for the patient, and in particular providing intensive care. So that is, I guess, it in a quick summary of distributive shock and how it relates to anaphylaxis and some things to consider as critical care paramedics. Thank you.